Hello, dear friends. Good morning, good afternoon, good evening, where you are. So I'm Mohammed Saghir Khan, pediatric oncologist from Saudi Arabia, co-chair of SIOP Global Health Network, along with my fellow co-moderator, Dr. Naureen Mushtaq, pediatric oncologist from Pakistan and leading pediatric neuro-oncologist in the region, and having a lot of activities in pediatric neuro-oncology over the last 3 years or so. So we welcome you, we warmly welcome you to this new initiative. Welcome from SIOP Global Health Network and SIOP DiSPLeN team. This is a disease-specific portal for learning and networking, which is designed to offer some more educational offerings to pediatric oncologists working particularly in low resource settings. So I was told that we have more than 400 registrations for this first webinar, which is quite delightful for us. And we expect that we could have very good participation also. So I have a little bit, brief introduction about this webinar and about DiSPLeN. So let me quickly go through it. So as I said, its acronym is Disease Specific Portal for Learning and Networking. This is the background is that SIOP has more than 3,500 members for all around the globe. And SIOP focuses on improving care and cure of childhood cancers in all resource settings. And SIOP Global Health Network, GHN, addresses the unmet needs of children with cancer by fostering practical guidance for delivering cancer care for health professionals, caring for children living in low resource settings. SIOP GHN offers strong learning opportunities to its members through 7 working groups. So basically, we have a couple of recent surveys. One was SIOP GHN SWOT analysis in the beginning of this year. And the analysis showed us a strong demand from SIOP members, the SIOP GHN members, for disease-specific learning guidance on treatment regimens. Similarly, as you know, we had SIOP CEDAR project, which was conducted on early diagnosis as childhood cancer early diagnosis and appropriate referral. That was in collaboration with International Pediatric Association. And the surveys which we did conducted after the webinar sessions that showed strong interest about dedicated learning sessions on specific childhood cancers. So that's the basic background to launch this new initiative, which will provide additional opportunities for the SIOP members for on to learn for learning on various aspects of care and cure, directed but not limited to WHO index cancers, the common curable cancers. We would have various learning sessions on case-based discussions, diagnosis and referral pathways, access to care, advanced diagnostics and therapeutic modalities. And of course, we would invite SIOP members with enormous experience, disease experts like today's session. We have the world-renowned pediatric neuro-oncologist and the former SIOP president, Dr. Eric Bouffet. So this plan will potentially enhance SIOP membership engagement and contribute to professional nurturing of SIOP and SIOP GHN membership through these virtual education learning opportunity. So this is about SIOP DiSPLeN team, which includes the GHN core steering group along with SIOP Secretary General, disease experts, IPSO and ISO representation, and representation from the continental branches and some other GHN leaders. So you can find the website link on the SIOP website. You can find the DiSPLeN details with the members and objectives of this project. So we are in the pilot phase starting from this inaugural webinar. that will be of 6 months duration. The intent is to globalize the already existing smaller and regional groups on disease-specific learning, like Pakistan Neuro-Oncology Forum, which has prospered a lot over last 3 or 4 years. DiSPLeN team will coordinate education day sessions along with local SIOP Asia organizers during SIOP Asia 2025 Congress, which is going to be held in Saudi Arabia in April 2025. So I put the QR code. You can scan it and see the abstract submission and other details about the Congress. And of course, we would have 12th April dedicated for DiSPLeN sessions. The ultimate goals will be expansion of the project to non-English languages to engage global representation, connect with other projects within SIOP and SIOP continental branches, and actively interact with key global stakeholders and childhood cancer initiatives. So and this is about today's session. And the next session will be coming up on January 10th, 2025. We will announce the further details right after this session. Let me just introduce you some housekeeping instructions. So we will have a Q&A box. You can put your questions during the talk, and we will take the question. There is no voice option to just because it's a short session. So we would just encourage you to put your text, and the question will be answered through the text, or there will be a dedicated question and answer sessions time after the end of the talk. And of course, after the session, you will be sent a link for the survey about this session that will help us to generate some information about effectiveness and impact of these sessions. So we would really appreciate you to interact during the session and also give your kind feedback about this session. So thank you so much. Let me hand it over to my fellow co-moderator Naureen Mushtaq to introduce the case-driven discussion and the speakers. Thank you so much. Over to you, Dr.
Thank you so much, Dr. Saghir. A very good day, good morning, good evening, everyone. So I'm really happy, and it's a privilege for me to introduce you to the disease-specific portal for learning and networking by SIOP. And it's a great initiative by Dr. Saghir and team to improve the knowledge of the basic and the GICC associated cancers. So the first one is about low-grade glioma. And my colleague, Dr. Farah Bashir, who is a pediatric neuro-oncologist working at Khan University Hospital, Karachi, Pakistan, is going to present a case. And afterwards, we will lead the discussion with Dr. Eric Bouffet. So over to you, Farah.
Thank you very much, Dr. Naureen. Am I audible to everyone?
Yes.
And my screen visible? Okay. So I am Dr. Farah Bashir, and I am a pediatric neuro-oncologist at Khan University Hospital, and I'll be presenting a brief short case discussion. So this is a case of a 12 years old girl that presented to us in 2020 with a 1-year history of headache, blurring of vision, and tinnitus for past 1 year. There was an increasing tendency of vertigo and vomiting for 15 days before she came to us with 1 episode of generalized tonic-clonic seizures. Upon history and examination, only the cerebellar signs was positive. We did an MRI on 2nd November 2020 that showed an enhancing lesion along the right lateral ventricle. So we planned a surgery. She underwent right frontoparietal craniotomy, followed by resection of the lesion and insertion of the right AVD. And that happened after 1 year of 1 year from starting of the symptoms. So the first scan is the preoperative scan that is showing a mixed contrast enhancing lesion in the right cerebral region involving the right lateral ventricle. The second one is the post-operative scan. So on the post-op scan, which was done after 72 hours, that showed a suspicion of a residual disease. And the histopathology that was reported initially was disc embryoplastic neuroepithelial tumor, WHO grade 1. However, when we followed up the case after 3 months, there was an interval increase in the residual lesion. So we decided to discuss this case in the International Tumor Board and was advised to review the pathology. So the sample was sent to SICKETS, and the report was low-grade glioma, and the tumor was KRAS mutated. We did a follow-up MRI after 3 months in May 2021 that showed interval progression. So this was the MRI that showed a progression of the lesion. And this was the pathology report. So the next was to go for a second look surgery and a neuronavigation guided right-sided craniotomy and maximal safe resection of the lesion was done in June 2021. And the histopathology was consistent with the low-grade glioma. So the patient, after June 2021 surgery, the patient remained on regular surveillance. Initially, it was 3 monthly and then 6 monthly. So on the last MRI in July 2022 and in the serial scans, there was a small flare hyperintense nodule along the medial margin of the resection cavity. But our plan was to wait and watch and do regular surveillance for the patient. So the current status of her is that she's a 16 years old girl with stable disease. There are no signs and symptoms, and she is a student of 11th grade, and she comes on a regular follow-up. So at 4 years post-diagnosis, she is doing well and stable. And this is the last scan, which was done in December 2023 with a small nodule, the enhancing nodule at the medial margin of the resection cavity. And we are following the case. For the last 2.5 years after the surgery, she's doing well and she's okay. That's from my side.
Thank you so much, Dr. Farah. So now we will start our discussion with Dr. Eric Bouffet. So everybody knows Dr. Bouffet. Dr. Bouffet is inspiration to many to become a pediatric neuro-oncologist, and he's my mentor. He's the professor of pediatric oncology from the Hospital for Sick Children, Toronto, and also a visiting professor of our University Hospital. So Dr. Bouffet is the past president of SIOP. He has many, like more than 600 or 700 a publication to his name, has done a lot, improved many children's life. And he's here to discuss about the do's and don't in the pediatric low-grade glioma. Over to you, Dr. Bouffet. So Eric, you are mute. Eric, you are mute.
Unmute. Okay.
Oh, yeah. Okay.
Yeah, I need to go back to my first slide. Thank you, Saghir. Thank you, Naureen, for the invitation. Thank you, Farah, for the introduction, and thank you, everyone, for attending this session. I'm talking to you from Shenzhen in China, so it's 10 p.m. here, and I'm traveling the world as a passionate pediatric neuro-oncologist working in China for 2 weeks at this time of the year. So I wanted to take the opportunity of this presentation to review a few things about low-grade glioma, and perhaps the most important is it's not to repeat talks about chemotherapy or targeted treatment, but just to say how complex and how difficult it is to manage this condition. First, because this condition is so diverse. There are low-grade glioma everywhere in the central nervous system. They can be in places where they can be resected surgically, and this patient often only sees a neurosurgeon. But they can also develop in bad places where the role of surgery is limited, even if sometimes surgeons are trying to attend what I call heroic surgery. And I want to comment on this a bit further in a few minutes. So what makes low-grade glioma complicated is that there was a time where it was easy. It was like when in the early 20th century, there were only one or two factory making car, and so people knew about every car because they were either one car or the other. Now there are hundreds of different cars, and it's the same for the low-grade glioma. Not because people have developed a business around it, but people have learned about and they have identified numerous different types of low-grade glioma, and it's becoming increasingly complex. So that's why in many large institutions, there is a dedicated pediatric neuro-oncologist. In smaller institutions, it's not always possible, but it's difficult to keep up with the information. And I put a little star here just to show where is the tumor that we just mentioned or Farah described. It's a disempleoblastic neuroepithelial tumor, also called DNET, which is part of the category of glioneural and neural tumors. But you can see that there are different types of low-grade glioma, the circumscribed associated glioma, the pediatric type diffuse low-grade glioma. And so and different sub-entity in each group according to their histology, the morphology, but also according to their molecular alteration. And so for many, it becomes increasingly complex, and people say, no, I cannot keep up with the information. And the information is on this slide. In fact, most low-grade glioma, and when I say most, is 95 to 99%, are driven by an activation of called the MAP kinase pathway, which means that if you look at the bottom, it's a pathway that is leading to cell proliferation and activation of all the pathway, like if there was an acceleration of all the processes. And in this MAP kinase pathway, there is one which is called the mTOR, and that's the activation of the mTOR pathway, and the other one which is activation of a RAS pathway. And you can see that FGFR is here. So if you have an activation through FGFR, like we have in this patient, so it can activate the whole pathway, but you have also different way to activate. For example, you can see the MIB, which is an angiocentric glioma, or the KRAS. You can see the KRAS can also be an activator of the pathway. So basically, and we will see this later. So if you have a low-grade glioma and you can block the pathway, and the best way may be just to block here downstream, where you say, okay, I'm the goalkeeper, I'm going to block everything here. But these drugs are not yet available. So maybe I can stop the progression of the tumor. So what about FGFR? So this tumor, I think, was had an alteration of FGFR, right? So FGFR has been described in DNT, and this is a paper from the team in Montreal that described around 100 patients with DNET. In fact, only 43 were confirmed, and 23 had an activation through FGFR. So FGFR is a big molecular alteration in DNT. So, but when we talk about low-grade glioma, the problem and the question is, what is my responsibility and what is the objective? And let's be realistic. Most patients with low-grade glioma will be long-term survivors. So this is a study that was conducted on the SEER registry from Boston. You can see Mark Karan, Dr. Bando Padayai, also called Mimi, and they look at the long-term survival, and 95% of the patients with pilocytic astrocytoma were alive 30 years after. So it's not about life and death. Of course, when you see diffuse astrocytoma, which are a different entity within the low grade, there is always a higher risk of survival of death, and we can elaborate on this. It's related to some of the molecular iteration and the aggressiveness of the tumor. But overall, when we deal with patients with low-grade glioma, we are not going to talk about life and death, and it's more just to talk about success. And that's where the notion of success is very important, because your role as a physician is going to, determine whether this patient will be cured successfully or whether it's going to be a catastrophic success. And you have all the, description of this. You have patients who are long-term survivor with absolutely no, very few side effects, and you have patients who are long-term survivor, and every time you see them in the clinic, you feel ashamed because their life is a misery. And low-grade glioma, it's really one of the diseases where we can talk about art in oncology. So it's, like music, it's like about conducting an orchestra. You need just to make sure that you think not only of today, but you think ahead of time. And of course, there are the surgical low-grade glioma, and that's the example of the pilocytic astrocytoma of the cerebrum, where you will not see this patient. The role of surgery is fundamental, and this patient will be cured by a surgeon who has some pediatric expertise. There are still some discussion about how often you should scan these people, and the main discussion is, because this low-grade glioma is going to be cured by surgery, can we think or can we extrapolate and say that all low-grade glioma can be cured by surgery? In fact, one thing we know is that if the surgeon cannot remove completely the tumor and is leaving a small residue, don't irradiate. So you can just observe, and most of the case, the tumor will not change and will not progress. So don't irradiate these children with an incomplete resection. The problem is sometimes the low-grade glioma, and very often, grows into a place where surgery would be devastating. This is an optic chiasm. If you remove it, the child will be blind and may have a lot of other issues. There is no role for surgery, but we know from the data that there is a high cure rate. So the question is how you bring the child to the status of cure. And how can you predict the behavior of this tumor? Is he going to behave nicely or aggressively? We don't know yet. We have some idea because we know that, for example, infants, they have very aggressive low-grade glioma. Even if the molecular seems to be the same, they are more aggressive, and we have very strong data to show that they need many treatments for many years. And patients with NF1, by contrast, often they have very indolent low-grade glioma. And for this reason, there are a lot of, still questions that are unsolved. What type of chemotherapy should we give? What is the length of chemotherapy? What is the role of radiation? And how do we treat patients who are what I call the frequent flyer, who have multiple recurrences? I want to come back on the role of surgery. So this is a surgery that was performed by one of the surgeons at Saghir, and this patient had a spectacular recovery, was doing very well after surgery, but this is not always the case. So here this patient, which was presented at one of the teleconferences that I attend quite regularly, had this spectacular surgery for this very large suprasellar hypothalamic tumor. But then the question from the oncologist was, what should we give to this child in terms of chemotherapy? The child is blind, has diabetes insipidus, has swings with temperature, is hyperphagic, is very aggressive, and in fact eventually died a few weeks later. So this is what I call heroic surgery. And that's where you have a role yourself in advocating. And I want to show you a few patients like this. This child had the same type of tumor, and the surgeon say, I'm going to take out some tumor. And he removed, look at this, the top of the tumor. As a result, so the child had normal nystagmus after surgery, very low vision, and had pound hypopituitarism. Is this a success? This child is going to take medication for the rest of their life, just before a surgeon decided to remove this part. And the same for this other child. Look at this. They remove completely, and the child is blind and has hypopituitarism. So often you are just called when the damage is done. And that's why I say neuro-oncology is not only about a neurosurgeon, a pathologist, and a radiation oncologist. Neuro-oncology is all about working together as a team. Okay, and particularly you need to have people who talk to each other, and you need to develop a working relationship with the key players, the neurosurgeon, the radiation oncologist, and the neuro-oncologist. Of course, everybody here on this file is important, but as far as decision to treat are concerned, it's critical that you make sure that there is a dialogue before any decision is taken. Otherwise, this is what happens. The patient is left alone and it's a catastrophe. So I show you this child who had a very successful surgery, but the tumor board decided not to do anything. And you can see 3 months later, it was just already growing back. And the question is, what do you do here and how do you decide to treat? And this is always a question about radiation and chemotherapy. And traditionally, radiation was a standard treatment. But we have now good data on radiotherapy that suggests that it's not really a treatment that gives you a good quality of success or outcome in the long term. Or there are a number of issues, such as the risk of stroke, the risk of secondary brain tumors, the risk of endocrine deficit, and in young children, the risk of decline in cognition. Not that radiotherapy is bad, and you can see here that with the new technique of radiotherapy, you can irradiate much more specifically an area of the brain. So this is with photon, with modern technique of conformal radiation, with photons, sorry, here, and you can see you still have a large area of brain irradiated, but this is with proton. Of course, proton is not everywhere in the world. There are proton in North America, in some countries in Asia, in Europe, not in Canada. It's not a technique that is available, and often you have to deal with photons that give a much larger area of irradiated brain. And even if you say, I'm using the best technique, if I talk about stroke, that's an optic pathway glioma, and the stroke is related to the radiotherapy, to the large vessel. Even if you have a proton technique, you will give radiotherapy to the large vessel, to the carotid artery. So I'm not sure that this is going to change with the modern technique of radiation. So the question is, when you give chemo, you may wonder, why do I use chemo when the proliferation index is low? Should I wait, or is there any rationale for chemo to work? And we don't really know why it works, but it works. Look at this patient, had 1 year of chemotherapy, and look how much the tumor shrunk with chemotherapy. And response can be very slow. So this is a patient that I treated for 2 years because he was a very slow responder with initially some progression of his tumor. But look at his tumor at the end of 24 months of treatment. So it takes sometimes a little while. You shouldn't make any decision just to discontinue treatment and to move to radiation here because the tumor is bigger. You have to be patient in low-grade glioma, not to precipitate into the discussion or the decision. One of the difficult issues is just to decide when to treat and why to treat. And for example, when you look at the COJ recommendations, they are very, very vague and political. You treat when you think there is necessity to begin treatment because of a risk of neurologic impairment with progression. Every child will have a risk of neurologic impairment with progression. So basically, this is your responsibility and you will make your own experience. There are kids that I treat today that I would not have treated 20 years ago and vice versa. And then always ask the question, why do I treat? What is the main reason? What is the objective? If the child is already blind, if the child had a massive surgery, what's the reason I would treat this child? Okay, what is the benefit? The child will never recover his vision. So sometimes I challenge the surgeon and I say, so I will not treat unless there is a good reason to treat. But at this stage, this child does not need any treatment. So there are a number of reasons to treat. Cure is not really the problem, as I showed you. The response is certainly important, the visual preservation or the functional preservation, to delay or to avoid radiation treatment, essentially to minimize morbidity. And this makes low-grade glioma a chronic disease, in fact. This is like having diabetes. So you need just to make sure that the patient eventually has a life as normal as possible with as many disabilities related to the tumor or the treatment. And the big question is which treatment, which recipes with the French, the English, the US, the Canadian. And there are a lot of protocols. There have been quite a few protocols, not very, very many. SIOP LGG2, which was a randomization between vincristine carbo and vincristine carbo etoposide. In North America, there was some study closed a long time ago, 9952, which was a TPCV versus vincristine carboplatin. This one with temozolomide. We just finished the randomization vinblastine plus bevacizumab in Canada and Australia. And in recurrence, there were a few phase 2 studies looking at vinblastine, bilirubin, or temozolomide. I speak about chemotherapy here. But all the chemotherapy studies have pretty much the same profile. You can see that it works, and then the situation worsens over time, and you have a plateau at around 40% at 5 years. So that's all the chemo are doing pretty much the same. So in this context, you really need to look at other things. So what is the toxicity of the treatment? How can it damage the patient? Carboplatin vincristine is fantastic as long as the patient doesn't develop allergic reaction. So that's a problem. TPCV is much more aggressive and can have a risk, some specific risk. Etoposide cisplatin, which is used in many Asian countries, there is a risk of hearing loss. And I tell you, if you are blind already and you become deaf, it's terrible. It's just many of these children become autistic, in fact. So be very, very careful with this combination of etoposide and cisplatin. Temozolomide, very, very poor activity in low-grade glioma. And vinblastine and vinorelbine may be less active, but they have no long-term toxicity. So what we learn is that when you treat for the first time or the second time or the third time a patient with low-grade glioma, you have the same profile. It doesn't seem that you cause or you identify a lot of resistance. So which means that you can repeat the same chemotherapy. And I've treated patients with vinblastine or vinorelbine 2 or 3 or 4 times with the same response each time. So the concept or the idea of resistance to treatment is not really demonstrated. It's like if low-grade glioma, if you want to cut a weed and the weed is not dead, so the weed will grow back. And low-grade glioma is like this, and the weed one day, and many low-grade glioma, not all, will suddenly stop growing. And often it's around puberty. And suddenly you see that they go into what we call senescence and they don't grow anymore, like if they mature into a tissue that has no growth potential. And so this is the responsibility you have, is to take this patient throughout the journey until the tumors stop growing. And as I mentioned, we learned a lot about the last few years of the pathway involved. And I told you it's an activation of the MAP kinase pathway with the mTOR on one side, with the RAS on the other side. And for this reason, in many, many contexts, when you have a low-grade glioma, you can use some medication that are called targeted treatment. And the good one and easy to use are the MEK inhibitor because they can be used in any situation. Sometimes they don't work. Some work apparently better than other. Cobimetinib has a very, very disappointing activity. The four other, the selumetinib, trametinib, binimetinib, and mirdametinib, seems to have a very similar activity. But the activity is sometimes spectacular, and sometimes you see kids who progress on chemo, you put them on MEK inhibitors, they have a spectacular response. The BRAF inhibitor are exclusively for patients who have a BRAF mutation, and there are two drugs, vemurafenib and dabrafenib. Sorry for the mistake, it's vemurafenib. And we can combine them. Vemurafenib is combined usually with cobimetinib, and trametinib is combined with dabrafenib. And they have this new drug called pan-RAF inhibitor, and there are two currently tested in low-grade glioma, tovorafenib, also day 101, and plixorafenib, which is a drug which is quite interesting with very low toxicity profile. So you may say, yes, yes, we know, we heard about, but in low-income country, we have no access. In fact, we can have access, and that's a paper that came out a couple of weeks ago, thanks to the work and dedication and courage of Dr. Amayari, and she used a compassionate program with Novartis just to have access to dabrafenib and trametinib, and she could treat 20 patients in a institution with low-grade glioma with either trametinib or dabrafenib or the combination. So this is possible, and many people are doing everything they can just to make this program available to people working in low and middle-income countries, and particularly in the context of the Global Initiative for Childhood Cancer, because low-grade glioma, as you know, is one of the 6 index diseases. So I'm doing my best to advocate for the use and the introduction of this medication in the essential medicine for childhood cancer. So I want to wrap up and to tell you, most often we cannot undo what has been done. So the message here, when you treat a patient with low-grade glioma, is to discuss before and to have multidisciplinary meeting before any decision is taken. And if you don't know, it's important to ask. You ask colleague locally, or you ask colleague remotely, and just to see and to figure out what is the best option. It's not always written in the textbook, but it's better to figure out before than to ask a question after when it's too late. So this would be my main message today. And as I say, the treatment of low-grade glioma is art in oncology, and your responsibility is to make sure that the child can have a normal life when the tumor is going into what I call senescence. So I'm happy to answer any question you would have. And if you want to email me, this is my email. It's still active, and you can contact me at any time. Thank you very much.
Thank you so much, Dr. Bouffet. Such an excellent talk, and many of the queries have been answered in this. So there are some questions. So first of all, many are congratulating us in initiating this webinar series. And then there are questions related to the guidelines which we should follow for the radiation.
So I'm not a radiation oncologist, and
Yes.
you know, I have been advocating against radiation. It's interesting because I'm in China here with Derek Sung, who is a radiation oncologist at Princess Margaret Hospital in Say. So he has irradiated 2 children with low-grade glioma since 2019. So of course, we have the privilege to have access to targeted treatment. And so it makes a huge difference in the context of a high-income country. So the indication for radiotherapy in low-grade glioma are, they depend of a number of conditions. First, I would say always try to use chemotherapy first, as much as possible. And I would say perhaps at least 2 lines of chemotherapy. Of course, there are factors that are also involved, which is the age of the patient and the location of the tumor. So very important. And if the patient is an older patient, there is less concern about the cognitive impact. If the location is not what I call at-risk location, it's also less a problem. For example, a patient with a spinal cord low-grade glioma, I would not worry too much. But if the tumor is in the middle of the circle of Willis, we know, and there are very, very good data from our colleague, Dr. Dan Bauer, who has done a lot of work on stroke in low-grade glioma and in post-radiation, that patients who have radiotherapy in the suprasellar region have a risk of stroke that is 70 times higher than their siblings. So things that you need to anticipate. Of course, if you are stuck because the family doesn't want chemo, or the family lives too far away and it's very difficult for them to get chemo, radiation is in many cases the best option, and it can be life-saving or functional saving, can save vision. The message is take the best technique of radiation, conformal, 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 okay? Second is the margin can be very, very tight. 3 millimeter around the tumor bed, no more. So it's just a very, very conformal radiation treatment. You don't treat the same way low-grade glioma that you treat high-grade glioma with much larger margin. Don't try to irradiate as much as you can. Try to avoid to irradiate the brain around. You need very, very to squeeze your field of radiation. And and follow this patient because they may get complication even a long time after. Now I have patients that I have treated 30 or 40 years ago. I'm still in touch with them. I tell them most of my patients got meningioma. They got some complication, one or another. Meningioma is very, very common. And so they need to be followed because radiation is a treatment that can give you long-term side effect years after you have delivered.
Thank you, Dr. Bouffet. So there is another question, a very relevant one. What is the preferred duration of MEK inhibitors?
Yeah, so I would need more time for this, but as mentioned, the term of frequent flyer, okay? And I mentioned the term of frequent flyer because I'm a frequent flyer when I travel around the world. But you have kids who are frequent flyer because they come back to your clinic every once in a while because they need another treatment. And this is particularly the case for 3 categories of patients. One are the less than 1 year old. The second are the one who present with diencephalic syndrome, which is the syndrome where they are very skinny when they start. Okay, they are often hyperactive. They are often very happy kids. But this is a red flag. Diencephalic syndrome means that this low-grade glioma is more aggressive than the usual. And the third category are the kids with dissemination. So these kids we know, and we have data that show that their 5-year progression-free survival is below 10%. And they tend to recur and recur and recur again. So at this stage, there is no specific protocol. We have identified that this is a category of patients with high-risk low-grade glioma, but there is no specific recommendation regarding the duration of treatment. But if you look at them during the first 10 years of life, some kids, they receive 8 years of chemotherapy during these 10 years of life. Some, they receive 5 years of chemotherapy. We haven't put in place this protocol, but this is certainly the future, is to modulate the protocol according to the profile of the tumor. At this stage, most of the protocol for MEK inhibitors say 8 months to 24 months. Now, we had the luxury for the people who have participated in the early phase trial with Novartis. We had the authorization to continue treatment as long as the patient were showing benefit. And I tell you, in some institutions, some kids have been on MEK inhibitor for 5 or 6 or 7 years. Is this good? Is this bad? We are also learning about the long-term side effect. Will this affect growth, fertility, cognitive development? We are collecting data. So what, if I can make a couple of comments. So yes, currently it's 18 months to 2 years. What people say, if you stop and the tumor grows back again, you give the same treatment, you give a MEK inhibitor again. This is not that simple because we don't have clear data showing that if you give the same treatment, it works the same way. And we have, in fact, data that suggests a bit the opposite. The response after you discontinue is not as good as the response you have on the first use of the MEK inhibitor. And this is the same with BRAF inhibitor. So what, in particular, the Canadian group has put in place is recommendation for discontinuation. There was a time where children were just discontinued cold turkey, just tomorrow you stop the treatment. Now, more and more, the recommendation is tomorrow you decrease the dose by 25%, and we will see the scan in 3 months. And if the scan is good, then we will continue to decrease. It's just a more careful and wise way to discontinue treatment, and I think that's the new rule that we are applying to the use of this targeted treatment, is to say, let's do it progressively and not too quickly. And if we see that with the decrease in the dose, the tumor is growing back again, we will increase the dose back.
Thank you, Dr. Eric. So there is a very interesting query from Shiryas. It's about a 13-year-old boy with cervicomedullary ganglioma, BRAF V600E mutated tumor, very poor response to therapy, conventional therapy, surgically risk. Is radiation a better option than targeted therapy?
Very difficult question, but there was a work that was done by Dr. Tabori and Alvaro Lasaleta that looked at patients with BRAF V600E low-grade glioma and looking at the response to various treatment, including radiation. And it was quite striking to see that patients who have a V600, a BRAF V600 mutation and low-grade glioma have often a very poor response to radiation treatment. Less than 50%, and in fact less than 40% have sustained response. So do not expect radiation to be the magic treatment and to work the same way. And I would say if you have access to targeted treatment, a patient with a cervicomedullary tumor, I would prefer to start with targeted treatment. If it works, I would really enjoy and continue treatment for at least 3 years until I will start to decrease the dose progressively, as I mentioned before.
Thank you. So there are lots of questions. One question from Dr. Kabudi is, about the side effect in the growth of the children who received MAC inhibitors.
So the side effect, you have to be patient, but we are working on a global consensus with Darren Hargrave, and many of you will be contacted just to see. We have a Delphi questionnaire just to put together a paper on side effect and how to manage side effect of targeted treatment in low-grade glioma. So that's a work that we started this year with Darren Hargrave and a group of experts to make sure that we cover all the side effects and not only the skin side effects. There are cardiac side effects, there are ocular side effects, there are a number of issues that I cannot detail here. The literature, there is some literature, but not very, very specific and often incomplete. So that's why we wanted to have this global effort to answer this question. So, but the recent concern has been with tovorafenib, because in the publication on the phase 2 trial called Firefly-1, a subgroup of 20% of the children around showed some sort of a decrease in growth velocity. And there are two questions here. Is this a problem that is like bone fusion? And I think we can now rule out the fact that this is not bone fusion. And there was a recent report at the ISPNO 2024 showing that when you discontinue the medication, the kids, they catch up with their growth velocity. But still, the question is, did the MEK inhibitor trial collect information on growth? And it's not clear whether it has been collected properly. So what I would recommend is follow the growth of the kids and make sure that you document this. What we have seen so far is the majority of the kids have a growth spurt after the discontinued treatment. It's like a bit the same as what we see when we give intensive chemotherapy. It's well known in leukemia during the 6 months of induction and consolidation of leukemia, they don't grow by any centimeter, and then they catch up.
Thank you. So there is a very interesting question asked by someone, and it's about a 2.5-year-old male. They have about optic pathway glioma on conventional chemo. They're not amenable to resection. Lesion is not progressing on chemo, but isn't regressing as well. Until how long can we continue conventional chemo, provided child is asymptomatic?
Yeah, very difficult question. And I have no answer. So there was an old paper from Roger Packer when he started to report the result of vincristine carbo combination, and a bit disturbing that showed, very interesting response to vincristine carbo. But then he said, in fact, this is nice to see a response, but the kids who have stable disease, they do very well in the long term. And there is no evidence that response is a prognostic factor for long-term outcome. And this is the fact is the aim of the treatment is, of course, you like when the tumor is shrinking, and I showed you some scan of beautiful responses. But the most important is to switch off the tumor, is to make sure that the tumor doesn't progress anymore. And if the child is not showing any sign of progression, I would say you can discontinue your treatment at the end of the period that you have decided. Of course, be careful, but there are no data so far that suggest that this child tumor is going to progress the minute you discontinue treatment. Stable disease can lead to sustained control.
Thank you. So there is another question from Dr. Kabudi, and I think it's the same question we used to ask most of the time in our part of the world, and it's that we don't have the availability of any targeted therapy, any BRAF, any MAC inhibitors, and even we don't have the ability to do the methylation studies. So although we are in the process of developing methylation studies, but again, even if we have the methylation study, what would we do if we don't have the availability of inhibitors in our part of the world? So I think if we have a good response with vincristine carbo or weekly vinblastine, so what else can we do for our patients? Like we don't have, like, if they progress, so either go for a surgical resection or go for radiation. This is always a question in our mind, Eric.
No, that's a very good question. And I would say before 2010, we were all in the same boat. And so I think, for example, in Toronto, we haven't changed our radiation policy with targeted treatment. We were not irradiating patients before, very few, only the one who were just very, very difficult to control with chemo. And the targeted treatment has certainly changed because it's an oral medication, it's a different approach, but I don't think that it should change the philosophy of care. What is important is that you have a strategy for first line, second line, third line. And I remember in Toronto, we had for the first 5 line of treatment. Okay, and at the very end was temozolomide. I don't like temozolomide, but we say if nothing works, let's try temozolomide because there are some data that has shown response. But we started with vinblastine or vincristine carbo and then vinblastine. And then we had the often TPCV as a third line, just to make sure that we were prioritizing according to specific criteria, including the toxicity of the treatment. So now one drug which has certainly a great interest is bevacizumab, and the cost of bevacizumab has decreased significantly now with the generic. And it is a drug that is providing a lot of benefit in the context of low-grade glioma. It's unclear how and why, but we presented at the SIOM meeting the result of the first line, and it shows clear benefit as first line, but I think at any time you can combine it. And if you don't have any targeted treatment, this can be a very useful medication. Now, as I say, our dream and aim is to introduce targeted treatment in low and middle income country. I'm very, very happy to see that the Firefly-2 trial is going to open in some middle income country, in Argentina, maybe in Brazil, in Jordan, so in Egypt. Of course, it cannot open in all middle income country, but it's happening. And with advocacy, I think we can make this happen.
Thank you. Thank you, Eric. So there is another one about everolimus as an mTOR inhibitor. So the role of everolimus in low-grade gliomas.
Yeah, I'm a bit uncomfortable here. I have seen the data. I've seen the data in NF1 and in non-NF1 patient. Both the response rate and the progression-free survival are not great. They have been published in very good journals, but I'm not convinced. It could be an option, but clearly, if you compare the data with chemotherapy or, of course, with targeted treatment, mTOR inhibitors do not provide the same enthusiasm. Most of the patients have stable disease. The progression-free rate, I think, in the paper from Daphne Kogan is progression-free 66% at 1 year, which is not very good. You could see that with vincristine carbo, it's 66% at 3 years. So that's really not a good comparison. Now, there is a trial conducted with PNOC that is trying to combine mTOR inhibitor with MEK inhibitor, because when you look at the pathway, you say, if I block the two pathway, the mTOR and the RAS, it should be spectacular. But the problem is when you use a combination, it's quite toxic. So there were some issue in trying to find the right dose. I heard from different sources that this trial is now up and running. They found finally the right dose. And we'll see whether the combination of mTOR inhibitor with a MEK inhibitor may be one of the good solutions. But as a single agent, I'm not convinced. It still has a fantastic role in SEGA in the context of tuberous sclerosis. And this is a wonderful treatment in the context of SEGA.
Thank you so much, Dr. Eric. So I'm afraid we cannot ask more questions, but this would be an excellent session to have and so much learning. So Dr. Saghir, do you want to conclude?
Yeah, thank you so much, Dr. Eric, Naureen, and Farah. You can imagine, I can't imagine because we had webinars previously. In this webinar, it's 47 comments and questions so far. So you can see the level of enthusiasm and people are interested to ask so many questions. So because of we are over time rather 1 minute. So I would request all the participants who put the questions and we couldn't answer them, if they can send their questions to us on info at the rate of psyop online.org, the email which is posted on the brochure also. So we can try to get them back with the answers of their questions. And there was one question for Eric about sharing the presentation. Gladly we have recorded this session. Thank you, Anelia and SIOP office. So this webinar will be posted on SIOP YouTube channel. So it will be available as a resource. And that definitely what we were expecting, Dr. Naureen, before we started this first webinar, is there is a lot of demand for having such like activities. And thank you, Eric, for being so generous for this session and also answering so many questions. But there are many more. Another thing which we might consider in the future could be some radiation oncology talk, because there are some questions about radiation therapy. So we have radiation oncology representation in our DiSPLeN team. And of course, we would have plenty of time for those who are attending SIOP Asia in April 2025 to have more in-person discussion. So thank you so much again for participation. Thank you, Eric, Naureen, and Farah, and all the participants of this session. And we look forward to have you with us in the next webinar on 10th of January. Thank you so much.
Thank you.
Thank you. Have a great day. Thank you again. Bye-bye.
Bye.